Thank you. It's an honor. It's a privilege. I actually always like speaking to patients more than physicians. You guys listen more and are tougher on us, I would say, because you guys actually ask the right questions. Today, I'm going to give you guys an overview on the role of chemotherapy in prostate cancer. And a lot of this stuff was not even around when I was in training. And we'll go over some of the history and how fast prostate cancer, along with other cancers, is changing the landscape of medicine. And an informed patient is always a better patient because you guys know what's going on. So a very quick introduction. I'm not going to spend a lot of time on this. You guys have monthly meetings and you guys probably know more about prostate cancer than actually some medical oncologists. But it is a very prevalent cancer. It's the #1 cancer in males. And for deaths, it's the #2 cancer. In 2015, there was 220,000 cases of prostate cancer. And believe it or not, it's very similar to breast cancer. If you're a man and you get to live a normal amount of life, you have a 1 in 7 chance of getting diagnosed with prostate cancer. The average age is 66 years old, so that's why, again, we don't see a lot of young patients in this room. It's different than testicular cancer or lymphoma, some of the other cancers that are mainly in young people. And the good thing is that 90% of men are diagnosed with localized prostate cancer and have a 100% chance of living at least 5 or more years. And again, you wouldn't be able to say this for some of the other cancers that were up here. But the thing I put in the red, metastatic disease, and we'll talk a little bit more what that means, once the disease has spread, and it depends on how you want to define metastases, is incurable. So even though we have made a lot of progress, and 90% of men are diagnosed with localized cancer, once the disease becomes metastatic, it's incurable. And you need to be educated and knowledgeable how to treat the cancer, because every decision you make probably will either add or remove months from your overall survival. And because of that, it's the 3rd most common cause of cancer deaths in developed countries. So to me, prostate cancer is actually divided up into 2 subcategories. One is the localized disease and one is the advanced disease, or if you want to call it metastatic. And unlike other cancers, and this is what I tell a lot of my patients, you'll never meet somebody who comes and says, oh, I have pancreatic cancer, thank God, right? If you have pancreatic cancer, you're in deep trouble. If you have lung cancer, even if it's stage 1, you're in deep trouble. Prostate cancer is very different. You can either have possibly a normal lifestyle and not need to be treated, or you can have an incurable disease with a lifespan in months or years. So today's focus is mainly going to be on metastatic prostate cancer. You guys have, sounds like lectures and discussions, and other people will talk to you guys about localized disease. To me, the way I look at it is metastatic prostate cancer, and we'll talk about more what that means, is divided up into 2 categories. Hormone sensitive, sometimes called castrate sensitive, or castrate resistance. And the reason I put this in the red is because you do not want to get in this category, because once you get into here, the game is over. Hormone sensitive prostate cancer is also divided up into 2 categories, and we'll get into that. And usually, initially, everybody has a response to androgen deprivation therapy, to hormone blockade, but it's still incurable. And usually, in most men, on average, in 2 to 3 years on being on hormone therapy, they'll fall into this group, and their average survival will be 3 to 4 years. So you go from a cancer that was curable, normal life expectancy, once you get into this metastatic category, which we'll talk about, and whether you should give chemo earlier in this category, you have an incurable disease with an average lifespan of less than 5 years. Now, why do people get metastatic disease, and why does it become incurable? And this is more where we would have doctor discussions. It's either extragonadal synthesis, so other organs besides the testes. That's where drugs like Xtandi and Zytiga come into play. Gene mutations or other complementary pathways. Castrate resistance, this is where all the drugs in the past 5 years have been developed in. But again, the outcomes have not significantly changed. You're looking at an average survival of 2 years. So this is the staging, and again, I'm not going to go into this, that's not the point of our talk, but every cancer is defined into location, lymph nodes, and other places. And you can see once you get to the M, this is where the cancer has spread to either a lymph node, another organ, bone, this is when it's considered metastatic. But in prostate cancer, if you have disease in lymph nodes, which are the collecting system of the body, that is also considered metastatic. So it's not just disease that has gone to another organ, like bone or liver, it's also cancer that's gone to lymph nodes. And this is a picture illustration of that. So you can see stage 1 is cancer that's just in the prostate. Stage 2 is cancer that's in both lobes. Stage 3, it's coming out of the capsule. And stage 4 is whether it's in the lymph nodes, the green, or it's gone to another organ. So what are the treatment options for men that have metastatic disease, stage 4 or above? Up to 2004, treatment was very, very limited. There wasn't a lot of options. But since 2010, the landscape has changed a lot, and we'll talk about that. So this is a figure that I got from you guys, and you can see up to 2010, there wasn't a lot of drugs. The one drug that changed the landscape that we'll talk about was Taxotere, docetaxel, that was approved in 2004. Before that, there was all these other drugs that really did not have any effects on overall survival. So if you were diagnosed with prostate cancer in the 90s, these drugs were not that effective. 5-FU, cyclophosphamide, mitoxantrone. 2004 was the big landscape in prostate cancer, where the first chemotherapy that showed overall survival was FDA approved. And then you can see from 2004 to 2010, there was a 6-year lap where no drugs were approved. And then since 2010, again, what I told my patients, we live in the renaissance of medical oncology. There's a new drug getting FDA approved with different indications every couple of months. So this is the treatment landscape of metastatic prostate cancer in 2016, whereas in 2004 to 2010, it was just Taxotere. And we'll break up and talk a little bit about this. So these are the drugs that have been FDA approved since 2004. And again, you can see there was a 6-year gap, and then from 2010, all these drugs got approved. But this is what I want you to look at. It's still an incurable disease. Once you get to the metastatic setting, you're looking at anywhere from 19 months, 15 months, 25 months, 15 months, 18 months, 14 months. It's not a curable disease. No matter which drug you use, whether it's Taxotere that was approved in 2004, second-line chemo with Geftana, or called cabazitaxel in 2010, Provenge in 2010, Zytiga in 2011, Xtandi in 2012, and then the newest one, Xofigo, in 2013. For Taxotere, it was compared to mitoxantrone, which was the only drug in its counterpart that they were studying. And again, this becomes important because some of the chemotherapy drugs that I will be talking to you guys about, you guys should remember these names because that's what it was compared to. Provenge and Zytiga and Xtandi, these were compared to placebo. So if somebody got nothing in like Zytiga, they lived 11 months. If they got Taxotere, they lived 16 months. So again, a difference of about 4 to 5 months compared to placebo. So what should you do not to fall into this category? Because yes, it is very exciting, and I can come and say 1 drug since 2004, 5 drugs since 2010, but it hasn't revolutionized the disease. People are still not living 5, 10, 20 years. So there has to be a secret door not to fall into this trap, because once you fall into this trap and you attend all these lectures and all these talks and all these forums, and there's a lot of excitement, wow, 5 drugs since 2010, that sounds amazing. They found a cure to prostate cancer. No, they found ways to increase it by months. Whereas if you don't fall into this trap, you still can maybe live years or decades. So the goal of this talk is not to talk to you about all the advances we've made in prostate cancer. That, this one graph will show you. Nothing up to 2004, then 1 drug 6 years later, then we got 5 drugs. But it's still not the cure, not the answer, not where you want to be. So that is all the introduction I will give to you guys about prostate cancer, because you guys are a very educated group. But it's different than most of the lectures that I attend, where people paint this rosy, nice picture of, wow, we've made so much progress in prostate cancer. Yes, we have, because all these drugs have come about. But these numbers, to me as an oncologist, when I look at it, is still pretty grim for overall survival. These are two other trials that, again, people might hear about. All these things that I gave you, these are post-docetaxel, except Xofigo and Provenge. This is given pre-docetaxel, so if you decide not to get chemo and you go ahead and your doctor says, okay, I'm going to put you on Zytiga, you don't have to get chemo. I'm going to put you on Xtandi, and I heard the excitement about these drugs that you guys were talking about. You're still looking at, 34 months versus 32 months. And again, this is compared to placebo. This is compared to nothing. So you can see the difference is, about 4 months. Again, these people were treated afterwards with other agents, but you're still looking at, a couple of years like we talked about. So what's this magic drug that I'm going to tell you guys about? Taxotere. This is the compound. This is what it looks like if you go back into the infusion rooms and the hoods. And this is the mechanism of action. All our DNA is bound, and this inhibits tubulin formation. So that sounds, again, this is not a scientific talk, but this drug is revolutionary because it was approved in 2004, and it was the first chemotherapy in prostate cancer that showed overall survival. Again, I like to go back and show you guys this. They compared it to mitoxantrone, which was this drug that was available in '96. So when you compare docetaxel to mitoxantrone, what was the difference? People who got docetaxel lived 19 months. People who got mitoxantrone lived 16 months. So there was about a 3-month overall survival. So again, I said docetaxel got approved in 2004 and everybody was excited. But again, you can see the data is exciting, but not that exciting. And here they gave it at either every 3 weeks or weekly. And the good thing is that it's pretty tolerable. The main side effects for people who've had Taxotere is neuropathy, which is tingling in the hands and feet, fluid retention, or hematological, low white blood cells or anemia. Out of curiosity, and you don't have to raise your hand if you don't want to, how many people in the room have had Taxotere? Okay. And then the only other chemotherapy that was approved in the metastatic castrate-resistant prostate cancer was Jevtana. This was approved in 2010. And again, if you look at it, this was the TROPIC trial. It was 15 months versus 12.7, a 2.4 months difference. So is earlier better? If you give somebody chemotherapy earlier, do they tend to live longer? Do they tend to do better? Up to 2010, if somebody said, is earlier chemotherapy better? The answer was, of course, yes, if you had metastatic castrate-resistant disease, because there was nothing else anybody could offer you. Compared to mitoxantrone or placebo, it was better and you lived 3 months longer. 2010, when all those drugs came about that you guys have heard about, Jevtana, Provenge, Zytiga, Xtandi, and Xofigo, it became controversial. Do you want to give somebody Taxotere that's chemo, that you have to go and be infused, that you might lose your hair, you might get neuropathy, you might need a blood transfusion? Or do you want to get this magic pill, Xtandi, Zytiga? Do you want to get this sexy vaccine that, there's no other cancer that you can get a vaccine in? Do you want to get IV radiation in your veins? Wow, all these things sound so much better than getting chemo and looking like a cancer patient. So because of that, and Taxotere, I believe, is generic now. So again, there's not a lot of push to give people Taxotere. The recent shift, and this is based on population studies, the use of Taxotere has actually decreased instead of increased. And believe it or not, about 1/3 of patients do not ever receive Taxotere in their treatment of prostate cancer. And there is concern that there's possible loss of efficacy after treatment with novel anti-androgens. And the novel anti-androgens are Xtandi and Zytiga. Now, there is no way to prove this, and at the end we'll talk about some novel blood tests that you can do to see if you will respond better to Xtandi or Zytiga. But here, I can't give you an honest answer, is earlier better, because they have never studied these drugs head-to-head. So at this point, it becomes a clinician's decision of whether to give somebody chemotherapy or to give them an anti-androgen. And if you ask and you go to different meetings, you hear different answers. You'll hear Dr. Bob's answer. Dr. Bob has been giving Taxotere, I think even before all this stuff came about. So there's a reason you guys should definitely listen to him, because he knew what he was talking about. And coming from a university setting to the office, I'm always impressed of how did he know? How did he know that this data will be published? It's kind of like you doing something, you know, without actually having a lot of evidence, but then always being correct. So I don't have the evidence to tell you whether you should get Taxotere, Xtandi, or Zytiga. I would tell you my own clinical decision usually is that if you have metastatic disease, it's usually better to get chemotherapy, because eventually you'll be able to get the anti-androgens, which are pills. That's my opinion. Different doctors will give you different opinions. I don't speak for any other companies. I've been asked. I don't do it because then I would have a bias. But my bias has always been towards chemotherapy. But I would tell you that sequencing is controversial, and depending on which speaker you hear, because again, I'll keep on going back to my golden slide, they don't have any data. I know that you can't use Jeftana before Taxotere because this is approved as second line, but even that is going to probably change because they have data that might come out that Jeftana given before Taxotere might be better. And they might eventually have data that Taxotere before these is better, but it's not yet standard of care. I would tell you most doctors would use Taxotere if you have extensive disease. And usually extensive disease is disease in lymph nodes, organs like liver or lung, or extensive bone mets. But in the metastatic castrate-resistant setting, there is no data of whether you use Taxotere or the other ones, which is better. So it's up to you and to your physician to decide. You've heard my bias. You'll meet Dr. Bob in about half an hour. You'll hear his bias. But this is the data. So now we get to the metastatic castrate-sensitive prostate cancer. So just to remind you guys, what is the difference between castrate-sensitive and castrate-resistance? So we talked about that once you have disease, and again, sorry for going back and forth, but I want everyone to follow along. Once you have disease that's either gone into lymph nodes, and these are lymph nodes, so these are the collecting system of the body. You have disease that's gone to another organ, so bone, liver, lung, anywhere else. Or even look at this, T4. What is T4? So T4 is cancer that's gone to other sites of the prostate, such as rectum, bladder, or pelvis. Once you have metastatic disease, you're usually treated with androgen deprivation, with Lupron, Firmagon, these drugs. As long as you're responding, you're considered castrate sensitive, okay? You do not get these drugs. These drugs are only approved for men that have castrate resistant, men who do no longer respond to Lupron, to Firmagon, to anti-androgens. So once you stop responding to anti-androgen therapy and you become castrate resistant and you have an average survival of 2 years, then the FDA comes and says, pick your choice. You have all these drugs to pick from. But if you're in the castrate-sensitive setting, which means that you have disease that's still making testosterone, you cannot get Provenge, you cannot get Xofigo. So in those cases, what do you do, right? So again, you'll hear what Dr. Bob did for the past 2 decades, and he's correct, and this was just published in 2015. But if you went to your run-of-the-mill oncologist, they would say that you just would stay on anti-androgens because that was the therapy. And then that's the whole controversy of intermittent versus continuous. Do you stay on Lupron from the day you become metastatic till the day you can't walk into the doctor's office? Or do you get a break in between? And again, I'm not here to cover all of prostate cancer, but at least this way, when people throw out these terms, hopefully this lecture will help you understand, me clicking back and forth on my slides, where you fall into that category. So if you have metastatic disease that's castrate sensitive, so let's give some examples. You had radical prostatectomy and the disease came back in a lymph node. You had radiation therapy and the cancer came back in your hip. You did not have any therapy. You just presented to your doctor's office and you said, my back hurts, and they found out you have cancer in your bones. You are castrate sensitive because you have not had anti-androgens, you're a virgin, you're naive. So where do you fall in? Up to 2015, you should not have gotten chemotherapy. You should have just been given anti-androgens. Again, Dr. Bob will come and explain his approach to prostate cancer, which ended up being correct. And you guys said he's been coming here for 20 years, so he was giving you the talk 20 years ago. before all the data was published. But this is the landscape, so this is what I'm going to be talking to you guys about. Last year, for the first time in published phase 3 data, they showed that even to the guy who shows up, who's never had any hormone shot, but he has metastatic disease, if you give him chemotherapy, you will improve his overall survival. That sounds obvious to people now, or people who heard Dr. Bob, or other people who are advocating chemotherapy, but it wasn't until literally a year ago, attending these conferences, where they actually were able to publish data that showed that. And again, we'll get to the reason why maybe it took so long. So no standard of care till 2015. And the reason for that is because there is data in labs and experiments that actually giving simultaneous therapy is better than sequential. So if you give a guy anti-androgen, then you wait for him to become castrate, then you give chemotherapy, that's actually inferior than if you give somebody anti-androgen and chemotherapy simultaneously. The data didn't say that you give either or, it said that you should give both together. And this decreased the progression to castrate resistance. So I won't keep on going back to my slide, but remember, if you had castrate sensitive, maybe I should go back because that's a very important slide. So even if you have castrate sensitive disease, if you stay on anti-androgens, within 2 to 3 years, you will fall into this rat hole. So this showed that if you give chemo to those guys, you will, again, prevent that from happening, not forever, but you will extend the duration, and I'll show you guys the numbers. So here, earlier is definitely better. If you hear anything that I say, earlier in this stage is better. Now let's get to the data. The reason this was unsuccessful was because they did multiple drug combinations, and you saw before 2004 all those drugs, mitoxantrone, cyclophosphamide, if they didn't work later on, they weren't going to work, beforehand. So that's why they were all failures. And it worked in a subset of patients, but they were never able to show that it worked for a majority of patients. But in 2004, they got smart. They said docetaxel works. So then they started studying all this in 2004, and in 2015, they published the data. That's another take-home message. In medicine, it takes time. You can't just study something and give somebody an answer the next day. In some cancers, like melanoma, pancreatic cancer, where people live months to years, you can come up with the data. But in prostate cancer, where people are living years and years, you need about a decade to be able to show that something has efficacy, has survival. So 2004, when the light bulb went off that, hey, we have a drug called docetaxel, and it works, that's when they started doing all the experiments. But it wasn't, again, since a decade later when all the data came about. So this is the concept that's really revolutionary, and for the people who are attending the conference in September, I'm assuming that a majority of the talk will be on this, because this is landscape changing. This has literally been, when we go into conferences, doctors have been hearing about it since last year. Patients should be hearing about it. Now, he gave my introduction. I work, at Cedars-Sinai sometimes when I talk to the urologist. They haven't heard about this. They're still giving their patients anti-androgen therapy. That's incorrect. Earlier is better in this arena. And it's based on these 3 trials. And again, when I give talks to patients, you saw for Xtandi and all that stuff, I never mention Affirm, Prevail, all this stuff. But for these, you should really remember these names, because when you go to the meetings, they will talk about these names, and you'll have a head start compared to your counter patients. So it's the GUTUG, Charted, and Stampede. And yeah, in medicine, they can't give people easy names, so these are all international, some in the US, some in Europe. And we'll break down what these studies showed. So if you can understand the slide, you understand everything that I'm going to talk about for the next 20 slides, but I'll break this down. But what are some take-home messages? So these are the 3 trials: Charted, GUTUG, and Stampede. But look, started in 2006 to 2012, 2004 to 2008, 2006 to 2013. You guys know why they started these trials, because of what I showed you earlier. In 2004, they showed Taxotere can improve survival. In the GetUp trial, they had 385 patients. Now, as an oncologist, this always amazes me that based on 300-something patients, they will change the landscape for the rest of the world of how people are treated. So you better hope that you get some good patients on these trials, because if you get a couple of bad apples, it might really change how people are treated for years and decades to come. And that's why a lot of when the patients say, why can't I get on a clinical trial? Because clinical trials are there to cherry pick patients for the drugs to get approved or for the regimens to become part of standard of care. And the reason is because it's not based on, thousands and thousands of patients that people think about. It really is based on hundreds of patients. So if you get a couple of bad apples, it will change, 10 years of work that people have dedicated their lives to. So here they only took M1 disease. And again, maybe I'm going into too much detail, but remember M1 means that if it's spread to another site in the body, so bone, lungs, somewhere else. So they actually cherry-picked and they put, even though you were metastatic, they cherry-picked their patients to be sicker. Here they compared ADT, and again, sorry, here I'm going to start using abbreviations, but I used them earlier. So ADT is androgen deprivation therapy. So what does that mean in English? Lupron, Firmagon, Zoladex. So they compared somebody who had metastatic disease. Now this could have been metastatic disease, de novo, somebody showed into your office, they've never had any problem, and their back hurts and you diagnose them with metastatic prostate cancer. Or it could have been somebody who had radiation therapy, radical prostatectomy, hormone therapy, cryo, whatever, some local therapy, and then years later they had metastatic disease. But they were virgins. They still were sensitive to anti-androgens. They never had the Lupron shot before. So they were metastatic but castrate sensitive. So they gave them either ADT, which is androgen deprivation therapy, or ADT plus docetaxel, our favorite chemo, for up to 9 cycles. Now, could they have given them Xtandi, Zytiga, Xofigo? No, because these patients were sensitive. They were not resistant. They're trying to prevent these people from getting into the resistant arm where they have 2 to 3 years to live and then you have 5 drugs to pick from. The standard of care was just hormone therapy versus hormone therapy plus chemotherapy. They followed these patients for 83 months and look at this data. The progression-free survival was 13 months to 23 months. In English, that means from the time they started till they progressed was either 1 year versus 2 years. So you would say, wow, this drug really works. Then their overall survival was 47 months to 61 months. This wasn't statistically significant, so based on the GETUC trial, they actually said that chemo is not better. Now this trial has been criticized and ripped apart. Part of it is they only had 385 patients. Their overall survival for the sensitive ADT arm was actually much higher than other people. But we won't get into it. But the other trials kind of counterprove this, and again, with maybe longer follow-up or other data, this might change. The other thing was here they gave them 9 cycles, and you will see when we move around, all the other trials only give 6 cycles. Here, the same side effect. So these were the 2 trials that changed the landscape. One is Charted, and the other one is Stampede. Charted, you can see, had almost double the patients, 790 patients. Here, they only took M1 disease. And here they did the same thing, ADT versus ADT plus docetaxel. But here, they only gave it for 6 cycles. And the median follow-up was 29 months. And you can see it outperformed standard of therapy, which was just androgen therapy. 20 months versus 33 months for progression-free. And 44 versus 58 for the overall survival. So if you were to get chemotherapy for 6 cycles, compared to just hormone therapy, you would outlive your counterparts by almost a year, which in oncology is amazing because look at the other ones that I gave you, they were months, this is a year. And again, the side effect profile, this is for all grade 3 to 5, which means major side effects. Febrile neutropenia, which means you had low blood counts and you got a fever, was 6%, fatigue 4%, diarrhea 1%. Stampede, and this is the one you're going to hear more about because Stampede has a lot of arms we won't get into. Here they looked at 1,000 patients. This one they actually looked patients who were a little bit healthier. They took M0. But remember, M0 means you don't have disease in a defined organ in bone, lymph nodes. But 40% of their patients had M0 disease. And ADT, which is hormone therapy, versus hormone therapy plus docetaxel. Again, here they did 6 cycles, not 9, like the other one that didn't show significance. And look at it here. The median overall survival, this is for patients that had low-grade disease, 67 versus 77 months, and also 43 versus 65 months. I mean, you're almost getting, unheard numbers. If you showed these numbers in breast cancer, colon cancer, any other cancer, it would be a wow moment. But in prostate cancer, it was, in my opinion, a decade too late, but we have it now. And it is a wow moment in prostate cancer, because for the first time, you're able to show in studies that took place, from the mid-2000s till now, that giving chemo earlier did not improve people's lives by 1 or 2 months. You're talking about, maybe years, okay? And remember, these patients, and again, that's why I said if you studied that first slide, you would know everything in oncology in 2015 with regards to chemo. When were these people treated? 2004, 2006, 2008? There was no such thing as Xtandi or Zytiga or these drugs that we talk about. So if you actually had those drugs, maybe they could have even lived longer, because in these trials, when people progressed, they would go to the next standard of care. And for a lot of these people, there was nothing else besides docetaxel, because they were treated before 2010. So this data might actually be better if you started the study today and then followed patients for 10 years. That's another critique of these studies, that maybe they underplay the significance of actually giving chemotherapy earlier. So for metastatic castrate resistance, remember I told you I can't write yes. I can tell you what my personal feelings are, what some physicians' feelings are, but in the castrate sensitive setting, it's yes with a red exclamation mark. And again, this is up to your doctor's decision, because how do you define metastatic setting? You saw even within the 3 trials, they had different patient populations. In summary, they defined metastatic disease as patients that had 4 or more bone mets, or they had visceral disease in a liver, lung. But as I will show you moving on, that could even be taken into question, because why would you wait till you get disease in 4 lesions or in a spongy organ? Why not give it earlier? So it's better. Who might benefit? Younger versus older, bulky versus early relapse. These are all questions that need to be answered. And in all these trials, Taxotere was given at every 3 weeks, high doses. And I'll tell you, in our practice, I meet a lot of patients who come and say, oh, I got chemo, I couldn't tolerate it. They gave me a cycle and I ended up in the hospital. Who gets prostate cancer? Not the 20, 30, 40-year-old that a lot of times we use Taxotere. There's no magic about Taxotere. It's a chemo that's used in all types of cancers, breast, ovarian, lung cancer. So in men who are 66 years old and they get diagnosed with prostate cancer, then 5-10 years later they get metastatic disease, they're in their 70s, and you come and give them high-dose chemo, some of them can't tolerate it. All this is based on the every 3-week regimens, but there is also data that maybe you can give weekly versus every 2 weeks. Again, the original study, the study I showed you, was based on every 3 weeks, because the every week didn't show overall survival, but that was in 2004. Dr. Bob, who's here right now, he will give you guys, his take about doing weekly chemotherapy. To me, the idea is chemotherapy given earlier is better. And then the last part of my talk will be, so we talked about the metastatic castrate resistant, we talked about the metastatic hormone sensitive, but how about guys who are not metastatic, who just have high-risk disease, right? That's actually a lot of the patients. I started this talk by saying you don't want to fall into that rat hole of having metastatic disease. So once you get metastatic disease, even if you give Taxotere, even if you give it earlier, what were the numbers that I showed you? Your overall survival is still in months, right? So can we do better, right? Why should we wait 10 years for the data to come in? How about the guys right now who have high-risk disease? So the good news is that there's data coming out, and there's a lot of studies that are actually being focused in this area. My problem with that is, well, how do you define non-metastatic disease? Right now we have a lot of ways to detect metastatic disease, and unfortunately a lot of the patients that I meet, some of them don't have staging scans, and if they do, they just get conventional scans, CAT scans, bone scans. Well, how about if you start getting F18 bone scans on everybody? How about if you get C11 testing on anybody? How about if you send them and you get PCMA, or these special MRIs, or even on CTC, which is circulating tumor cells, or one of my favorites, these liquid assays where you can just get a blood sample from somebody and tell them their genetic profile of their cancer. So would you define those patients as metastatic? Would you define those patients that, no doc, you order too many tests and you're catching things earlier? When they studied these tests, these things were not even around. So again, what I tell my patients is, if you look for trouble, you probably will find trouble. And again, Dr. Bob will show you guys a slide. I think about 50% of patients, when they did bone marrows on autopsy who had prostate cancer, had disease there. So should we do bone marrows on everybody who has prostate cancer? So to me, this is a very challenging area, because how do you define, non-metastatic high risk? It depends who's looking to find metastatic disease, right? So if I send all my patients to get all these scans, you're going to find a lot of metastatic disease, where if they just went and got a regular CAT scan and a regular bone scan, they might not find it. But with that said, again, this is another busy slide, but I'll break it down for you guys. My point is that there's a lot of trials going on right now in guys that don't have metastatic disease, who have high-risk disease, and they're given chemo, and we're waiting to see what the endpoint is going to be. So again, another busy slide, but again, this is published in Frontiers in Oncology last year. So you can see there's a lot of trials that are looking at this, because they've hit a chord. They know that docetaxel works, and they know that the earlier you keep on giving it, the longer people are living. So they keep on peeling it one level back and one level back. So here I broke it down into different categories also for you guys to follow along. So this is non-metastatic, but people have had surgery. So our example is somebody goes, they get a radical prostatectomy, but you know that they have high-risk disease. And what's considered high-risk disease? They have positive margins. They have a high Gleason score. They have T3 or T4, where the cancer is coming out of the prostate. Later on, you find out that maybe they actually had something in their scans that was questionable. Again, they would be considered non-metastatic but high risk. So you can see in 2011, they published in SWOG that if you gave mitoxantrone after radical prostatectomy, there was no overall survival. But now you guys are all chemo experts. Remember, I showed you mitoxantrone is, it's not a good drug in prostate cancer. Why did they publish this in 2011? They probably started the study 10 years before. So that's one negative study. Here, the Scandinavian Prostate Cancer Group looked at radical prostatectomy followed by chemo for 6 cycles. Again, this was just presented in ASCO this year. They showed no disease-free survival. So you guys are experts also. What's the problem with this? They didn't give him anti-androgens. Remember, these drugs work synergistically. I showed you guys that if you give them in combination, they work better than if you give them in sequential therapy. So this was a study that was negative, but that's not the way we would treat them if they, in 2016, if they had metastatic disease. This is another study that's ongoing, CALGB. Here they gave chemotherapy and hormone therapy, so the way we like to give it, followed by radical prostatectomy. Those results are pending. This is for guys that had radiation therapy. So you have non-metastatic disease and you had radiation therapy. So here you can see the RTOG 9002. Here again, you don't like these chemos, right? The only chemo you want to see in prostate cancer is Taxotere. No overall benefit. This is Howard Sandler, who you mentioned, who's going to be talking to you guys. Here they gave radiation therapy plus hormone therapy plus chemotherapy, and you can see there was an improved overall survival. So what's the take-home message that I keep on telling you? That you need to do combination therapy of hormones and chemo together. If you just give one versus the other, you might not see the synergy and you might not see the overall survival benefit. Here, you see they gave it correctly and they got a progression-free benefit. And then these are all the ongoing trials that I don't have data for you, but my point is it's being studied. This is, again, Howard Sandler from Cedars that, again, you mentioned. This was the thing that all my patients tell me about now. It's called the Sandler study. I don't know why for this one he became famous, but not for the other ones. This was published in 2014, and he showed, compared to historical controls, if you give, after local therapy, surgery, radiation, if you give hormones and chemo, people tend to live longer. And then this is much more controversial. At least those people had evidence of high-risk disease. This is just for biochemical or recurrent disease. So how about if you had somebody, and this is probably most of the patients in this room, if you're coming to a support group, you had a radical prostatectomy, you had radiation therapy, and then your PSA is coming back up, right? So that to us defines metastatic disease, because again, if you search for it, you'll find it, but for most people, that's just considered biochemical relapse. At most, they might just put you on hormone therapy, which, remember, eventually will make you become castrate. So how about to these guys? How about if you give these guys synergistic hormone therapy plus chemotherapy? And here you can see there's 2 ongoing studies that will answer that question. Dr. Bob, who's going to speak after me, has been treating these patients with hormone therapy and chemotherapy for decades, and he will show you guys the numbers, and they're going to look much better than the months that I put up here for you guys. So what's the future landscape of metastatic prostate cancer? There's hope. You're living in 2016, not in 2004, so all these drugs are coming out, and they're learning that earlier you use these drugs, the better people will have outcomes. These are things that I just throw out, so if you go to meetings and people talk about it, you'll see how they fit in. AR-V7 is a very hot blood test that people check to see. Remember before I said I don't have data if you should get chemotherapy or hormone therapy if you're metastatic castrate resistant. This blood test is trying to predict who's going to be a failure to anti-androgens and would benefit from chemotherapy. Still not standard of care, but at least when you hear it, you know where to put it into the puzzle. This is the hottest thing at ASCO last year, that you can actually look for DNA repair genes, and if you find somebody that has the BRCA gene, which usually was associated with breast cancer, you can put them on an oral chemo, and we've used this in some of our patients. They're looking at combination and synergistic therapies, and this does not have to be only with chemo and hormones. How about if you add other drugs that have other benefits, such as controlling your blood sugar, controlling your cholesterol, controlling inflammation. So again, the idea of doing things in combination and synergy, the idea of doing continuous versus intermittent, and then again, even cabazitaxel, the chemo that again we haven't talked about because a lot of people don't use it because they use Taxotere and then the novel anti-androgens. They're actually finding ways of maybe giving it lower that's more tolerable. So again, this was just from this year's ASCO, that if you give it at a lower dose compared to the higher dose, you don't lose efficacy and it's more tolerable. So the future is bright because if we start using these drugs earlier, smarter, and maybe in combination, you might be able to make this like breast cancer where people can just, you can keep on extending survival every year based on more data. Again, I won't go into this, but this is to give you guys hope. There's a lot of trials that are ongoing in the metastatic castrate-resistant prostate cancer. And again, it's concepts that I want you guys to learn. They're combining abiraterone, which is Zytiga, plus Xofigo. They're combining Xofigo plus Xtandi. They're looking at Xtandi plus Zytiga. They're looking at chemotherapy plus, a novel drug. So maybe combination therapy is the way to go. Again, so many trials going on in prostate cancer. And then this I'll leave you with because we do this a lot in our office, and I don't know if a lot of patients are exposed to docetaxel again. So let's say you're the lucky guy who got docetaxel when you were hormone sensitive. Then 5-10 years later, you've been through Xtandi, Zytiga, Xofigo, Jeftana. Can you use that drug again? There's not a lot of data because, again, people were not living that long. Now we have people living. And here, this is just a prospective study that shows that if you re-challenge patients, you might actually be able to get some increased progression-free and overall survival. The problem is there is no phase 3 data. And then again, I throw in the sexy topic because you guys will hear a lot about this. This is called AR-V7. It's a blood test you can check on patients. Only specialty labs do it. And if you have this blood test, it will tell you whether you're sensitive for Xtandi, Zytiga, which are the anti-androgens, versus chemo. So in summary, I've told you guys a lot. Hopefully everybody followed along. Earlier chemo demonstrates efficacy and tolerability with improved progression-free and overall survival in the hormone-sensitive setting. Right now, it's only for bulky disease, which we defined as having 4 or more bone lesions or soft tissue. But I showed you a whole slew of data coming out that guys who don't even have bulky disease, they have earlier disease, they might do better. You probably have to wait 5, 6, 7 years to wait to get that data. I'm not talking to doctors, so I can tell you guys that a lot of my colleagues give chemo to younger, healthier patients because once you have proven that the wheel is going to go down the road, you don't have to wait till you see more signs. It's making sense, but it's not evidence-based if you guys want to follow pure evidence. The idea of synergy, trying to combine different pathways, has time and time proven again that it works in prostate cancer. It's still incurable, in my opinion. To anybody who calls me, who I do a phone consult with, who I talk to, in my opinion, if you get prostate cancer, you should always have a medical oncologist. To me, it's like playing football and not having a coach. You might be, never need one, but it's not always a bad idea. There's always newer testing. And again, you guys are spoiled because the urologists that you meet that come talk to you are urological oncologists, right? They're ahead of their field. They know all this data like me and all the other oncologists. Most of the community urologists, I tell you where I work, they don't know. You guys know more than them at this point. So whether you have a urologist who can give you a Lupron shot, urologists can prescribe Xtandi and Zytiga, to me, you always want to have that quarterback who's an oncologist, who's going to be your advocate, who's going to be pushing for you to maybe get things a little bit earlier. Because as I'm showing you, earlier is better, but it wasn't the case till 2015. So if you've been going to a urologist and they haven't, attended all the lectures you guys have attended to, you might miss out on that opportunity. And if you miss out, you might, miss the boat. So whether you get diagnosed with localized disease, advanced disease, and I'm talking to the wrong crowd because you guys go to support groups and you're educated, but if you talk to any of your colleagues, it's never late to get an oncologist on board. And I'm always amazed. You'll never meet somebody who has lung cancer. Stage 1 lung cancer, you meet an oncologist. You get pancreatic cancer, you get a pancreatic mass, you meet an oncologist, right? You get a cyst that looks suspicious, you meet an oncologist. A lot of times I'll meet patients who've had prostate cancer and have gone through hormones and Xofigo and Provenge, and then they're at death's door and they come in and they say, oh, my doctor told me to see an oncologist. So, knowledge is power, and if you have that connection with an oncologist, and here, whenever I give talks, I get excited because there's so much information I can share with you guys. The last talk I gave, we talked about imaging modalities, right? There's all these newer imaging that can detect metastatic disease. So if your doctor wants metastatic disease to give you chemotherapy, well, there's F-18, there's all these newer tests that you guys will go to these conferences and hear about. Well, a lot of the urologists, they're surgeons, they want to operate, they don't order these tests, they're not comfortable with ordering these tests, they don't want to follow up on these tests. So again, when you meet a urological oncologist, they actually are oncologists. So if you are just relying on a urologist to lead you along the way, my advice to you is change course, because they can give you Zytiga, they can give you Xtandi, those are pills. There is no urologist who will write you for chemotherapy. So, and you can see earlier chemo has been proven and proven to be better, and you want to have that coach who has that game strategy for you guys.
Thank you for your interest.